thumbs up if my audio video is fine, and welcome in the next session of dermatology with me, Dr. Chesta, your NEET PG educator on Unacademy. So I hope everything is fine, smooth. Just a second, let me see if you all can hear me and see me. Yes. So welcome in this session of PYQs in dermatology, where I will be discussing a lot of questions related to the questions which has been asked in the past. So I am Dr. Chesta, your NEET PG educator on the best online platform, that is Unacademy. You can download the Unacademy learning app and choose a category, that is NEET PG. Once you download and choose a category, you will have two types of subscriptions. One is Plus, which give you an access to Unacademy live classes from the top educators, and we have Iconic subscription, which can give you an access to both Unacademy and Prep Ladder. We do have special classes, so you can just download the app, go to the educator profile and start watching these special classes. You can use my referral code CHESTA10 for unlocking these free live classes. So welcome Waste and Aimsonian, welcome to this class. We have a highly effective question bank of around 25,000 plus questions with detailed explanations. These are some of our learners who have done very well in their recent exams. We have a feature which is known as raise a hand, so if you have any doubt, just raise your hand and ask your doubt. These are the free class rituals for the month of December, as well as for the paid classes for this month. The two new batches which I wanted to talk to you about is the Focus FMG batch, which is starting on 22nd or started on 22nd, and the Target NEET PG batch, which has also started on 22nd of this month. We do have a lot of offers which do come. Okay, now we have this type of subscriptions. Kindly use my referral code CHESTA10 and get your subscription today. You can go for a shorter subscription of 3 months or 6 months if you are targeting the NEET PG 2022 or FMG, or you can go for longer subscriptions of either Plus or Iconic if you are targeting the next year exams. So please, whenever you go ahead, kindly use the referral code CHESTA10 to get yourself enrolled. Starting with the first question of the today's session. Identify the following lesions. Becker's nevus, hypopigmented macule, Spitz nevus, or epidermal nevus. There is a hyperpigmented patch which is present on the upper trunk of this patient. Identify the following condition. Very nice, Hemal. What about the other students? So I think now you can answer the questions in hurry. Saurav, Waste Fellow, what about the answer of this question? Identify the following condition. Please remember, if you look at this image is the part of the trunk, upper trunk, which shows hyperpigmentation, and it is having an associated increased hair. So when you have hyperpigmentation with associated hairs which suddenly increases in size during the adolescence, always think about Becker's nevus. Very, very important. The correct answer is option number 1. Moving to the next question. Very nice, Venkateshan. Anybody else want to answer this? Saurav, Hemal, Waste Fellow. I hope you can see the image. I can move the image a little on the left so that it becomes better visualized. Which of the following medicines taken during pregnancy is responsible for defect seen in the child below? Ferrous sulfate, isotretinoin, folic acid, or metoclopramide. Which of the following medicines taken during pregnancy is responsible for defect seen in the child below? Very nice. The only drug which is not given during pregnancy which can cause teratogenicity or birth defect is isotretinoin. Please remember the correct answer is option number 2. It is very well known for causing the defects like cleft lip, cleft palate. So you should have at least a 1 to 3 month free drug-free period. After stopping the isotretinoin, there should be pregnancy only after 3 months, because before that it is considered that we do have the isotretinoin in the blood. Next question. Name the solid lesion of more than 0.5 centimeter. Anyone? We have Venkatesan, Sarika, Hemal. Anyone can tell me the answer here? Now please remember, this is a question from the basics of dermatology. What is a papule? It is a solid raised lesion of less than 0.5 centimeter. Plaque is a change in consistency which can be either raised or can be either depressed, which is of more than 0.5 or 1 centimeter. It is a fluid filled lesion of less than 0.5 centimeter, and nodule is a solid lesion of more than 0.5 centimeter. So the correct answer becomes option number 4. Next question. Which of the following cell is not present in the stratum basale layer? Which of the following cells will not present in the stratum basale layer? Anyone? Anyone? Hemal, Sarika, Venkatesan. Now please remember, we have total 4 cells in our epidermis. These are keratinocytes, melanocytes, Merkel cell, am I audible and visible? Very nice. A child after taking medicines for fever presented with the following picture. Most likely diagnosis of the following. Anyone? Very nice. For this particular question, please remember the correct answer is Stevens-Johnson syndrome. Why this is Stevens-Johnson syndrome? Why this is not a case of erythema multiforme? Because here you see targetoid lesions with 2 concentric circles. In the center it is dark and in the periphery it is red. So you have dusky center, and there is red periphery. Dusky center and red periphery is what is seen. But as we have discussed in this question, here if you look at this image, there are 3 concentric circles. One is dark, then it is light, and then it is again a red color. This is how target lesion of erythema multiforme look like. Please remember, in erythema multiforme also oral lesions are present, and in SJS also oral lesions are present. So oral lesion is not something which differentiate between the both. It is the type of the lesion, because in erythema multiforme we see target lesion, while in Stevens-Johnson syndrome we see targetoid lesions with 2 concentric circles in them. Moving to the next question. Which of the following options, the following conditions occurs? First of all, tell me what is the diagnosis of the image shown here. What is the diagnosis? Kanya, Siddharth, Hemal, Ashish. What does this image shows? What does this image shows? This is a case of, very nice, parakeratosis. Parakeratosis pustulosa. This is a case of parakeratosis pustulosa, and please remember, in parakeratosis pustulosa, when you do an histopath, you see parakeratosis, while in actinic keratosis also, when you do an histopath, you will see parakeratosis. So that is the difference or similarity between both these conditions. We had come across this similar questions, I think yesterday or day before yesterday, where the image was not given and they have only asked that in which condition you see parakeratosis, if you remember. Very nice. Now the next question is, a 25-year-old girl with erythematous papules on the face as shown in the figure. The lesions are exacerbated on exercise, sweating, sun exposure, emotional disturbances. What will be your diagnosis? What will be the diagnosis here? Anyone? Very nice, Aliya, Hemal, Venkateshan. Very nice, Kanya. Absolutely right. Please remember, this is a case of rosacea. This is a case of rosacea. What is rosacea? When you develop erythematous papules pustules over a background of telangiectasia, which gets exacerbated or remitted in a middle-aged female. Very classical of acne rosacea. Can anybody tell me how to treat this patient? Aliya, this is not SLE, because SLE will never exacerbate or will increase in the size of the lesion. No, the malar rash remains the same. Okay, it will never increase, never decrease. What about acne rosacea? What about acne rosacea? Why steroids are contraindicated in rosacea? Because please remember, if you give topical steroids, they can exacerbate rosacea by creating more erythema, more telangiectasia. So you never give topical or oral steroids because it can precipitate rosacea. It can cause the same features like that of rosacea, thinning of skin, flushing of skin, telangiectasias, etc. And that is why we also prevent it. And why acne steroids are contraindicated? Because acne is an infective condition. So when you give steroids in an infective condition, what happens? Definitely it will flare up. So in both these cases, you will never give topical steroid, at least, never. Okay? Now, for taking care of rosacea, you have to give doxycycline or metronidazole because they are secondary to microorganism, that is Demodex. You can even give some of the vasoconstrictor like brimonidine, latanoprost. All these things will cause reduction in the vasodilatory property and will improve the condition. For taking care of the thickening of the skin like phymatous rosacea, you have to give some of the lasers. Very nice. Next question. Very classical image of something. Very, very classical image. "35-year-old male, purple red oval macule after taking metronidazole, history of similar lesion at the same site 6 months back. What is your diagnosis?" What is your diagnosis? Erythema multiforme, urticaria, annular lichen planus, or fixed drug eruption. Amazing. This is a very classical image of FDE. Please remember this image. Whenever patient gives you a history that he takes a particular drug and following that drug he develops the lesion on the same site. For example, 4 years back also, 3 years back also, he has taken the same drug and he has developed the lesion on the same site, and now also patient has taken the drug and he has developed the lesion on the same site. So this tells you that you are dealing with a case of fixed drug eruption. Next question. This is a frequent repeat. I have seen this question being asked in FMG twice. Even NEET PG they have asked this question. AIMS also we had this question in past. So there are few questions which are actually favorite for examiners. Okay, and one of them is this. And nowadays another favorite question is the question from Pellagra. Back to back, all the exams have Pellagra questions. Okay, so if you are preparing for any of the exams, please do read Pellagra. Okay. Ma'am, why isotretinoin is used in melasma? No, we do not use isotretinoin in melasma. Who told you? We never give isotretinoin for melasma. No, never indicated. Okay, so this is a very classical case of segmental vitiligo. A very classical case of segmental vitiligo, because you can see that it is present on the single segment, not crossing the midline. Very, very classical of segmental vitiligo. Moving to the next question. Can you tell me what is the answer here? The newborn child with solitary white, well-defined patches on the left thigh, what will be the diagnosis? Solitary patch, well-defined, what will be the diagnosis? Newborn, please remember, they are asking newborn. And look at the lesion, the margins are not smooth, they are rough like this. The margin is not smooth, serrated margins along with the history present since birth. Please remember, it's a very classical description of nevus achromicus, which is also very popularly known as nevus depigmentosus. Very popularly known as nevus depigmentosus. So try to remember all these features. They are very, very important for all my dear students. Now, okay, Anantaman is asking them why it is not focal vitiligo. So please remember, Anantaman, what is focal vitiligo? If I make a new image, just look at this picture. Suppose this is the human body. Okay, what do you mean by focal vitiligo? If they have small size lesions anywhere on the body, please remember, it can cross the midline. It can cross the midline. So this is a focal vitiligo. It is a focal vitiligo where you have small lesions which can be present anywhere on the body, irrespective of the midline. But segmental vitiligo, what is segmental vitiligo? Segmental vitiligo never crosses the midline. If this is the midline, it is present on the single side, it never crosses the midline. It can be either on the trunk or it can be on the face, but it never crosses the midline. And in single patient, it occurs on the single dermatome. You never see multiple lesions, either this or this. But focal vitiligo can have multiple lesions on both the sides. Clear, all of you? Can you give me a thumbs up if this point is clear? Clear? Anantman, please give me a thumbs up. Moving to the next question. A very classical image of something. Very nice, all of you. The test likely to help in the diagnosis of itchy annular plaque on the face is gram stain, potassium hydroxide mount, tissue smears, or wood lamp. Focal is multiple or single. See, Hemal, what I am trying to tell you, focal can be multiple, can be seen on both the sides of the skin or both the sides of the body. But segmental is always on a single segment and it will never cross the midline. And that is how we differentiate focal from segmental. Understood or not? If you have understood, I request you to give me a thumbs up or say yes. Okay? So this is a case of tinea faciae, and for tinea faciae, potassium hydroxide mount is the answer. Next question. 50-year-old male with presented to dermatology OPD with violet color patch on the wrist or the dorsum of hand. Doctor noticed following characteristic lesion in the patches. Which of the above clinical condition is wrong? Which of the above clinical condition is wrong? Amazing, all of you. So this is a case of lichen planus. In lichen planus, you see combinous phenomena, that is on giving the trauma. At the site of trauma, you will see the development of the lesions. Oral cavity shows reticular type of lichen planus. And you can also see the extension of the proximal nail fold onto the nail plate or nail bed, which is known as dorsal pterygium. But please remember, you will never see positive Nikolsky sign in a patient of lichen planus. Nikolsky sign is a feature of vesiculo-bullous disorder. It's a feature of vesiculo-bullous disorders. Amazing. Ma'am, Wood's lamp can also be used for tinea, right? Ananthaman, please remember, Wood's lamp is only, or the Wood's lamp can only be done when the causative organism is Microsporum species. But tinea faciae can be seen secondary to trichophyton or even epidermophyton. In those cases, you cannot use Wood's lamp because it will not help you for making the diagnosis. And that is why in the past question, or in the previous question, we have marked KOH as the best possible answer. Understood? Okay? We cannot use Wood's lamp for all type of tinea. Only for tinea capitis, Wood's lamp can be used as one of the diagnostic aid. Clear? Can you say okay if you understood? Again, I think it's a very easy question. A patient presented to you with the history of white lacy pattern and there is history of amalgamated tooth. This amalgamated tooth is a very characteristic feature. Amalgamated tooth is a very characteristic feature of lichen planus. Very characteristic feature of lichen planus. Is this clear to all my dear students? ठीक है जी? Clear है? Should I go to the next question? Yes. Please answer the next question given on your computer screen. I hope you all can see. Is this visible? A 40-year-old male presented with following lesions. Immunofluorescence shows IgG in the intercellular space. What can be the most probable diagnosis? So two very important point here is first intercellular IgG and second is presence of oral cavity lesions. Both these gives you an idea that you are dealing with Pemphigus vulgaris. Ananthaman, why amalgam? Amalgam is a most common predisposing factor for oral lichen planus. I request Amalgam to please attend my Plus course which is going on right now on Unacademy Learning App. You can download the Unacademy Learning App today. Start watching my free live classes which is known as special class. Use this code if they want or if you have to unlock them. If you like those classes, you can even get a Plus subscription using the same code. Get it for 3 months and complete all the 19 subjects along with dermatology with us on Unacademy. Okay? Next question. Anybody? Aliya, Venkatesh, Kanya, Hemal, Pooja. A middle-aged lady presented to the OPD with painful blisters on the skin and the oral mucosa. Direct immunofluorescence was done. All of the following are true about the disease pathogenesis except. All of the following is true about the disease pathogenesis except. Hemal, the dermatology course is 20 hours. The dermatology course is 20 hours. I will be completing the whole dermatology in 20 hours. So you can definitely come and join it. And please remember, from dermatology we are getting around 13 questions. This year we have 13 to 15 questions from derma. 13 were direct and 2 questions were derma micro integrated questions. So if you are getting 13 questions from a short subject like dermatology out of 200, it is a very important subject for your exam. So please subscribe Unacademy, download the app and kindly use my code Chesta10 to get Unacademy subscription. Very nice. The correct answer is option number 3. In Pemphigus vulgaris, you have IgG type of antibody against both desmoglein 3 as well as desmoglein 1. The concentration of desmoglein 3 antibodies are more, and that is why you see suprabasal acantholysis. But you do see desmoglein 1 antibodies as well. Where do you see IgG antibodies against hemidesmosome? In which vesiculobullous disorder you see IgG against hemidesmosome? It is a feature of Bullous pemphigoid. It's a feature of Bullous pemphigoid. Is this clear to all my dear students? It's a feature of Bullous pemphigoid, a very, very important vesiculobullous disorder. Moving to the next question. Aliya, Siddharth, Pooja, Anant, then Kanya, Hemal, Venkateshan. I hope everybody have understood the question. Very nice. A 35-year-old female with painful blisters over the oral mucosa and the genital areas. She gave a history of similar lesions in the past. A biopsy from the lesion showed suprabasal cleft on histology. Immunofluorescence microscopy reveals intercellular IgG deposits as shown below. What is the most likely diagnosis? Dermatitis herpetiformis, Pemphigus vulgaris, Behçet's disease, or allergic dermatitis? What is the most likely diagnosis? Very nice, all my dear students. Very well done. The correct answer is again the same, Pemphigus vulgaris, because you can see a fishnet pattern, painful blisters of the oral cavity, IgG deposits. Moving to the next question. Moving to the next very important question. Patient comes with itchy tense blisters on normal skin as well as over the urticarial plaque as shown in the image. What is your diagnosis? Pemphigus vulgaris, Bullous pemphigoid, linear IgA disease, or dermatitis herpetiformis? Very nice. Please look at this image. If you look at the image very, very carefully, you will see that there is a large central blister with multiple small vesicles on the margin. Large central blister with multiple small vesicles in the margin. This is known as cluster of jewel or string of pearl appearance. String of pearl appearance. Cluster of jewel or string of pearl appearance. Cluster of jewel or string of pearl appearance. Very nice. Please answer the next question on your computer screen. What is the most likely diagnosis of the condition? Please look at the image very, very carefully. In the image you can see that there are presence of papules and pustules on the forehead. Nothing else is given, and they have given you a history that the patient is 40-year-old male. Anybody can tell me the correct answer of this question? Anyone? Very nice. Please remember the correct answer of this question is option number 2. This is not seborrheic dermatitis. Can you tell me seborrheic dermatitis is the disease of what age? Do you see seborrheic dermatitis in 40 years? No. Seborrheic dermatitis occurs during adolescence when the sebaceous gland becomes more functional. Here you can see the forehead with papules and pustules. What do you see in seborrheic dermatitis? You will see greasy scales, but that is not seen. So this is a case of acne rosacea or the papulopustular variant of acne rosacea. Option number 2 becomes the best possible answer for this question. Tell me the correct answer of the next question. Tell me the correct answer of the next question. A 15-year-old village-dwelling female presenting to dermatology OPD with an erythematous indurated plaque with a pseudovesicular border, what is the most favorite diagnosis? Most favorable diagnosis? Anyone? What is the most favorable diagnosis? Anyone? Anantaman, Kanya, Aliya. 15-year-old village-dwelling female presenting to dermatology OPD with an erythematous indurated plaque, pseudovesicular border, what is the most favorable diagnosis? Amazing, all of you. All my dear students, very, very nice. The correct answer to this question would be option number 4, sweet syndrome. What is sweet syndrome? It's a neutrophilic dermatosis which classically presents with fever along with erythematous patches. Now what happens when you see the margins of the lesions, you will see erythema as well as pseudovesiculation, which is a very, very important feature. Okay? Next question. Next question. Hemal, Kanya, Anantaman. Anybody can tell me the correct answer of the next question? The lady comes with complaint of bluish lesion over the left side of the forehead, left eyes, irregular bluish lesions in the left superior conjunctiva, forehead. What will be the most probable diagnosis here? Which is the most probable diagnosis here? A lady comes with complaint of bluish lesion over the left side of the forehead. Very nice. It's a case of nevus of Ota, which is a dermal melanocytic proliferation. The melanocyte during embryogenesis, it remain arrested at the level of dermis and they start proliferating there, giving rise to these lesions. Next question. A 30-year-old male has a large foul-smelling, spreading, exuberant ulcer with bright red granulation tissue over the glands. No lymphadenopathy. What will be the most likely causative organism? Which of the following will be the most likely causative organism? Treponema pallidum, Haemophilus ducreyi, herpes simplex, or Calymatobacteria granulomatis? Calymatobacteria granulomatis. What is the most likely causative organism? Very nice, Siddharth. Absolutely right. Now you can see that the lesion is looking very bright, exuberant, and if you touch this gland or touch this lesion, then it starts to bleed. In a patient with no lymphadenopathy, very, very classical diagnosis of Donovanosis, also known as granuloma inguinale, also known as granuloma inguinale or Donovanosis. The correct answer is option number 4. The correct answer is option number 4. The causative organism for granuloma inguinale is Calymatobacteria granulomatis or Klebsiella granulomatis. Next question. Female with the hair loss involving crown, frontal scalp, with the maintenance of the frontal hairline. Which of the following is the correct answer? Alopecia areata, anager effluvium, male pattern baldness or female pattern baldness. Very nice, all of you. Aliya, Hemal, Kanya. Diagnosis of a female with hair loss involving crown, frontal scalp and maintenance of the frontal hairline. Please remember, the correct answer is, see, there is only crown, frontal is maintained, so it is female pattern. It is a female pattern hair loss. But if there is bitemporal recession, then it is male pattern hair loss. Next question. Siddharth, Kanya, Aliya. Anyone? Yes, you are right. It is known as Ludwig classification. Absolutely right. Child with soreness in the mouth, rash on the hand and feet with the image shown. What is the causative agent for this? Coxsackie A16, pox virus, herpes virus, human papilloma virus. Which of the following is the correct answer for this pandemic? Child with soreness in mouth, rashes on the hand. Which of the following is the correct answer? Hemal, in Ludwig classification, we usually get the widening of the or the thinning of the crown part or widening of the part, and in Osland it is only the thinning of the crown. Okay. Please remember, this is a case of Coxsackie A16 and the diagnosis is that of hand, foot and mouth disease. Diagnosis is that of hand, foot and mouth disease. The diagnosis is hand, foot and mouth disease. Patient comes with the following lesions on his shoulder, chest. The lesions are scarring in center, increasing on periphery. The most appropriate treatment for this condition would be? Most appropriate treatment for this condition would be oral steroids, anti-leprosy treatment, anti-TB treatment or oral terbinafine or oral terbinafine. Patient comes with the following lesions on his shoulder, chest. The lesions are scarring in center, increasing on the periphery. The most appropriate treatment for this condition would be? Very nice, Aliya, Kanya. This is a case of lupus vulgaris. If you remember, we have discussed this question few days back. Whenever they give you a history that there is a lesion with scarring at one place and activity at another place, it can be the center or it can be one pole, and it can be periphery or it can be another pole, that case should be suspected as a case of cutaneous TB, most frequently lupus vulgaris, and for those cases you have to give anti-TB treatment. Okay, clear all of you? Now moving to the next question. Patient with HIV has white plaque on uvula. Pseudohyphae was seen on microscopy. What could be the likely diagnosis? Candidiasis, hairy leukoplakia, herpes or squamous cell carcinoma. Herpes or squamous cell carcinoma. Patient with HIV has a white plaque on uvula. Pseudohyphae was seen on microscopy. What is the likely diagnosis? What is the likely diagnosis? Yes, the correct answer of this question is option number 1. Candidiasis. The correct answer of this question is candidiasis. Next. Anyone? The patient with leprosy has painful lesions on arms as shown. He is also febrile. He is given a drug which increased the numbness of hand and feet. What could be the likely diagnosis? clofazimine, rifampicin, thalidomide or prednisolone? Anybody? Very nice, Alia, Siddharth, Hemal. Amazing, all of you. This is a case of type 2 lepra reaction where the most preferred drug is thalidomide. And the common side effect of thalidomide is peripheral neuropathy. Other than peripheral neuropathy, it can cause somnolence, peripheral edema, constipation, teratogenicity, etc. Clear? Next. A 28-year-old boy has asymptomatic dome-shaped lesions on the forehead. This question we have done, I think, day before yesterday only. This is how a patient of molluscum contagiosum look like. Please look at this lesion. They are pearly white, shiny, and from the center, can you see this white material coming out? In the center, there is a depression or umbilication through which the white material comes out, and that is nothing but infected keratinocytes containing Henderson-Peterson body. Henderson-Peterson body. The infected keratinocytes with Henderson-Peterson body. Look at this image again. On the lower lip, you can see the crust which is getting deposited. On the lower lip, we have a crust which got deposited. Which of the following is the correct answer? Very nice, amazing, all of you. This is a case of non-bullous impetigo, which is also known as impetigo contagiosa. Streptococcus infection is very commonly seen, and there are few strains of streptococcus like M49 which can even lead to development of the it can lead to development of the glomerulonephritis. Which of the following is untrue regarding piebaldism? Which of the following is untrue regarding piebaldism? Autosomal dominant condition, amelanotic skin associate. This I think we have done. Why not A? Okay, so in bullous impetigo, please remember earlier that you see warnish crust. You will not see yellow colored crust. Okay, and that is why it is not bullous impetigo. Plus, in bullous impetigo, you will have bulla initially, which then rupture to form a warnish crust. Here in the image, you can clearly see that it is yellowish honey colored, which is more classical of non-bullous impetigo compared to bullous impetigo. This is a very easy question. It's a case of piebaldism, which never improves with age. So the incorrect statement becomes option number 4. Diffuse form of hyperpigmentation is seen in, I think it's a repeat question again. Very easy. Please remember, all 3 of the above or all 4 of the above will have the diffuse hyperpigmentation over them. So with this, we are done with the today's session. I request all my dear students to subscribe Unacademy. Please use the referral code Chesta10. You can also subscribe to the YouTube channel, that is Let's Crack NEET PG. Please hit the bell icon to get the notification of my all classes, and also subscribe to the Telegram group with the same name. I hope you have enjoyed this class. We also have another session tomorrow also. So I request each and everyone